So I took some liberty with the cases I present, as I figured high risk can be defined in many ways. I would argue from our perspective, even minor complications are high risk of resulting in dissatisfied patients and frustrated surgeons. So I want to present interesting cases. I think an alternative title would be cases with no right answer. We will highlight the key learning points, takeaways, and benefits of participating in the Facebook group. These are my disclosures, which aren't relevant to this talk. So our first case is posted by one of our chairs today, Dr. Olasky. She posed more of a theoretical patient. How do you treat a patient with a hiatal hernia, GERD, and systemic sclerosis? Assume a normal manometry. As a brief review, systemic sclerosis or diffuse scleroderma is an autoimmune disorder of the connective tissue. 90% of patients will have GI involvement, which can be present anywhere in the GI tract, but the esophagus is most common. About half of those patients will be symptomatic. We see atrophy of the smooth muscle in the lower 2/3 of the esophagus and the lower esophageal sphincter. Muscle is replaced by fibrous tissue, and there's increased collagen deposition in the lamina propria and submucosa. The dysfunction is likely more related to neuronal abnormalities that are observed as well. When the esophagus is involved, on manometry, you may see a hypotensive LES and low amplitude contractions or even aperistalsis in advanced cases. They often suffer symptoms of GERD, and an endoscopy may reveal the long-term sequelae of that, including esophagitis, Barrett's, and strictures. So our first poll, if you could bring that up, let's get your opinion on this. So what's the best approach for treating a hiatal hernia in patient with systemic sclerosis? Are you doing a hiatal hernia repair with a Nissen, hiatal hernia repair with a partial fundoplication? You're going to do a bypass, or you don't think an operation is a good idea, you're going to stick with medical management alone? So we'll give you a few seconds. It's not working.
We're holding it for a few seconds so that you can't see what everyone else is answering until it shows. Oh, you can't answer.
Is anyone else able to answer? That's. I was like, wow, that's a great consensus.
Mine went through also. So
Okay.
I don't know.
Yeah, mine went through as well.
Okay. Can we see? Those are the final results? Okay. Well, apparently our room is pretty homogeneous, so that's surprising. But so, can we go back to the presentation, please? What did our Facebook participants think? Dr. Wright suggested an algorithm of a toupee in those patients with peristalsis and medical management alone in patients with aperistalsis, noting that scleroderma patients can progress to lead pipe esophagus and that operations on aperistaltic patients should only be offered for patients with severe complications of GERD, not solely for symptomatic control of heartburn. Highlighting another useful aspect of the group, links were provided to relevant literature. In this case, it was a retrospective review from last year in surgical endoscopy on this exact topic coming from the Cleveland Clinic group. They found 14 scleroderma patients they had operated on. 100% of patients who underwent Roux-en-Y gastric bypass had improvement or resolution in their symptoms, while only 50% of the fundoplication patients experienced the same, suggesting a Roux-en-Y gastric bypass may be the preferred option in this patient population. Moving on to our second case, Dr. Al-Ali posted a case of a frail octogenarian with a relatively asymptomatic paraesophageal hernia who chose not to undergo surgery after hearing the risks. He dies 3 years later when he has an acute volvulus, leaving our poster wondering if he made the right choice. Our next audience poll, if we could bring up the next question, please. I think we've all seen these patients. How do you handle an asymptomatic large paraesophageal hernia in an octogenarian who doesn't want surgery? You respect their choice, leave it at that, take the risk. Do you try to convince them to have something less invasive, like a gastropexy or a PEG, or convince them they're going to die if they don't have an operation and drag them to the operating room? I'll give you a few seconds to get your answers in. Hope our chairs are voting too. Okay. Wow, I'm impressed, guys. So everyone seemed to think that you should respect that patient's choice. So let's see. What did our online community think? Some suggested gastropexy as a reasonable option in high-risk patients. Dr. Pittman felt that those break loose too often and suggested high-risk patients should be offered a double peg technique. Some were adamantly opposed to this, feeling it was morbid, and most patients tolerate a formal repair. You'll also be reminded of relevant literature. Dr. Rodriguez provided support to the poster that he had done the right thing and referenced the landmark paper by Dr. Ratner. I think it's worth reviewing if you aren't familiar with it. This was based off an analytical model comparing elective lap repair to watchful waiting. They utilized estimated input variables from pooled analysis of published studies and large administrative databases. This study was utilized for input variables for the watchful waiting group. It is a case series of 71 patients with a follow-up survey. The majority of patients were repaired with fundoplication, but there were 29 patients they managed conservatively. Of these patients, 45% developed severe symptoms, ultimately requiring elective surgery. Thus, the annual probability of progression is 13.87%. The probability of needing emergent surgery was estimated from a pooled analysis of 5 studies. This graph depicts the risk over time, ultimately demonstrating the risk decreases significantly the older you get. The annual probability of developing acute symptoms requiring emergent surgery was estimated to be 1.16% per year. Thus, the argument for not offering elective operations to paraesophageal hernia patients that are minimally symptomatic. I also want to highlight what I think is so amazing about social media in this group. When you're feeling alone or you're doubting yourself and you just need to hear from a group of people who understand what amazing things you do for your patients every day, you can get that. In this case, the majority of responses were simply support that the poster had done the right thing. Our next case is brought to us by Dr. Ramaswamy. She reports a 46-year-old male with a demestre of 49 complaining of heartburn and chest pain. Manometry demonstrates good bolus clearance, but only 10% peristaltic swallows and 90% simultaneous and with normal DCI. The question is, how do we handle these patients with ineffective esophageal motility? Our next poll, please. So what would you do for this patient? And I don't know if you noticed, but there were 40 comments on this post, so it was highly debated. Would you offer them a partial fundoplication, a Nissen? Would you get more information, whether that be with like a Marshmallow study, or say, I don't really know about this outside manometry and I'm gonna repeat it here? Okay. There we go. Like I said, this was a popular post. So it looks like we're pretty evenly tied here with a partial fundoplication, which is always a safer option, and just repeating the study. Can we go back to the presentation, please? Thank you. So some of our posters wanted more information. Options included performing a Marshmallow or a bagel swallow test to determine if the patient can tolerate a Nissen. The importance of actually seeing the tracings was stressed, and some felt it was better to just repeat the manometry at your own institution if possible. So this topic has come up on the forum before. What is a Marshmallow swallow test and what is its utility? We know that contraction amplitudes required to empty a bolus will vary with the consistency of that bolus. Thus, a challenge with only liquids may not be enough to identify clinically relevant IEM. An alternative substance that is both of solid consistency and large enough size may provide a more accurate challenge. A common solution to this is to give a standard marshmallow cut to 1/3 or 1/2 of its size, coated in barium. Studies have demonstrated that this can induce dysphagia when a stricture or abnormal motility is present. Another article looked at the sensation of globus sensation, and the Marshmallow had the highest diagnostic yield at 71% compared to barium tablet, pudding, and liquids. For this case, Dr. Bittner and Dr. Gatta were willing to jump in with a toupee, so they agreed with probably about half our group here today. While others argued that the patient's IEM was only secondary to his GERD and would improve with a Nissen. Some posted they were concerned about the longevity of a toupee in this young man and would hedge towards a Nissen for that reason. Ultimately, Dr. Ramaswamy was able to have a more informed discussion with her patient, who chose to proceed with a toupee fundoplication. And I actually had the opportunity to ask her yesterday. It's a year out now, and he's doing well. I think this case highlights the nuances in what we do, and that sometimes there just isn't a right answer, but our patients benefit from the experience and different opinions of a larger group. Our last case is posted by Dr. Spear-Hefner. She describes her status post-Heller patient who had a negative intra-op leak test and a negative upper GI. He's post-op day 2 and tachycardic with a JP amylase of 120. Her question for the group was how to handle this. Again, a topic that generated some interest with 43 comments. So we'll go to our next poll question. What all would you do as your next step? Do you just keep the patient in PO and start antibiotics and wait? Get a CT scan, take her for an endoscopy with potential intervention if you find something, or are you going to the OR for a diagnostic lab? And we'll give you a few seconds to get your answers in. Okay. Here we go. Okay, so not a complete homogeneous response there. Go back to the presentation, please. Okay, so some respondents thought more imaging, such as an upper GI or a CT, were reasonable. Dr. Wright enlightened us that the protocol for that CT is very important. You need to make sure radiology knows that the patient needs to drink some contrast while on the table. Another option would be to evaluate endoscopically and then plan for intervention if the leak is found. Options include stenting, intraluminal vac, and internal drainage. And of course, you always have the option of taking the patient back to the operating room. If you have a high clinical suspicion, there's nothing wrong with a negative re-exploration. If you do find a leak, there's of course debate as to how to handle this. Options include closing the leak and covering it with a door, a simple mental patch with drainage, or just adequate internal and external drainage. What I thought was probably the most debated and educational of this post was the discussion around leaving a JP and checking JP amylase. A 2009 article from JACS was referenced. This is a prospective study looking at routine drain amylase measurements in post-op day 1 Roux-en-Y gastric bypass patients. There was a statistically significant difference in these values for the patients that were later confirmed to have leak. Except for one patient, the leaks patients all had drain amylase of over 400. Analysis revealed that a level less than this had a negative predictive value for a leak of 99.6%. A level over 400 was very sensitive but had a low predictive value for leak. Now, of course, that was for gastrojejunal anastomosis. They may be different for esophageal leak. This study looks at gastroesophageal anastomosis and gastric pull-ups following esophagectomies. They found an amylase level of greater than 250 on post-op day 4, had a specificity of 95.9%. Ultimately, Dr. Spear-Hefner took the patient back for a negative exploration and was supported by her peers for that decision. So this was just a sample of the types of cases you can see in the group. My conclusions are really why I think participating in the group is worthwhile. You get instant consultations with a large peer network, exposure to resources and literature, moral support when you need it, entertainment, and finally, you may make some friends in the process. Thank you.